Thank you, thank you for your magnificent self-quieting behavior. I'm Kurt Stange. I'm on the faculty here. I have two things that I'm supposed to do. The first is to tell you about a rule. It's a slightly different rule than when you're having lectures here. It is socially acceptable and actually expected to get up during the talk to get seconds or third or fourths. No one's counting. The baklava is over there. The second thing I want to do is tell you about the Diane and Ed White lectureship. And if you read the brochure, you know the story, but some of us in the room knew Ed White. He started in a solo practice and built up what's now a very large practice, Southwest Family Physicians on the west side, mostly hospitalized at Southwest General, built it up to a big practice. And is a loyal alumnus of the medical school here. And when he was working for the Alumni Association, just calling his classmates to seek donations, he talked to a classmate. It wasn't a close friend, but a classmate of his, Frank Yatsu, who was a neurologist, an academic urologist in Texas. And asked Frank how he was doing. He said, "Well, not really doing that well. Why is that?" "Well, he's having kidney failure and he actually needs a transplant, and it doesn't look like he's going to get a transplant." So Ed talked about the donations and asked him what his blood type was, and talked to his wife Diane and called him back the next day and offered him one of his kidneys, and gave him one of his kidneys. And so Dr. Yatsu donated the money for this lectureship into an endowment, so this lectureship can go on, and it's named for Diane and Frank White. So Diane and Frank White Lectureship in Family Medicine. And Heidi Gullett is going to introduce the speaker. I just want to mention the topic of the speaker. We thought it would be good just to give you a sense of some of the range of what's possible. Robin Gottler, whom I meant to introduce at the beginning, to do a brief commercial interlude, and I will do that in a second, has been doing some interviews of some of your classmates or some of the people in the room about how you see the future of healthcare and your place in it. And one of the things that's come up in those interviews is most people just assume they're going to be employed by one of the systems. And I think our speaker probably assumed that too. I don't know, you'll tell us your story. But there's other options, and so that's where our speaker's going to talk to us about one of the options.
Just before I introduce our amazing speaker, a few housekeeping items. So some of you are used to this room, and some of you have never been in here before. So I know that Umair will want us to have a dialogue. So if you want to say anything, we are recording this because there were a number of people who were not able to attend tonight, but were really interested in the talk. So in order for them to hear, if you can just press down and hold on the silver button in front of you, it'll turn from red to green. And when it's green, then you'll be able to be heard through the mic, and then Umair can hear you too. This is really just so good for my soul tonight. I feel like I have come home with my people. There are just a number of incredible generalist physicians in the room, some educators, some in community practice, many medical students, and it's just really, really great. A lot of us haven't seen each other in years at this point, although I do have some of my three of my current practice partners in the room, which is also really exciting. So thank you all for coming and just sharing in what could be a really big movement in this country around how we actually want to see relationships and we want to see primary care. And I think we have an amazing speaker to tell us about his way of doing that. So Umair is incredible. You probably read his bio on the thing that was sent out so you knew about tonight. So I won't reiterate all that, although I think he'll share some of that probably when he talks through his story with us. But what I wanted to share was just some personal anecdotes of Umair. So we first met when you were an intern a few years back, and we shared a lot of hours together in ambulatory clinic, on labor and delivery, on the inpatient service, and Umair was the kind of resident that makes you so grateful for your job as an educator. Really always teaching me a lot, challenging me as the faculty member, but also incredibly supportive of everyone on the team and very, very humble, and also teaching our patients what it was like to have a family medicine physician who cared deeply about them and was in relationship with them. So when I heard that you were opening your own DPC practice, I knew that it was an incredible fit for you just based on the kind of doctoring I saw you do as a resident. And so it is just a great joy to have you here tonight, knowing what you did as a resident, and now we get to hear about how successful you've been and how you're really trying to impact our world for good. So thank you so much for coming, and with that, love to hear from you.
Well, thank you, Heidi, for the intro. You guys can hear me in the back? Yeah, great. So I'm actually really humbled to be here because a lot of my mentors are here, as you can tell, Heidi being one of them. And I've always held case students to be in high esteem, so thank you for having me and hearing me out. And as Kurt alluded, I did never envision myself as a young child and adolescent growing up, picturing myself as a doctor. I never thought of myself working for a large corporation. It was never really my dream. The dream was, primary care. I wanted to be a family doctor, someone, working on the frontier, maybe something you see in one of those old TV shows. And as is the case with a lot of dreams, reality sets in and life takes over, and you don't really lose your dreams, they just shift and they transition. And so as I completed my family medicine residency, it just became sort of natural to end up in a very large practice, a hospital system. And I never really realized that was a problem or was a deviation from my original dream. So a little background, I am Canadian. I was born in Montreal, Canada. So I grew up with socialized medicine. So I have a fairly good understanding of how that works. I lived there most of my life. I went to medical school at St. George's University, and my first year was abroad in Newcastle, England. So I got to see a little bit about what the healthcare system was like there. I then did a year in Grenada in the West Indies, which I call that no healthcare system. That's sort of essentially, there really isn't a system, although it was a great education. And then I finished up in the US. So, I feel like that gives me some experience in worldly, deliveries of care, along with some of the global health work that I did when I was a resident here at university hospitals. So I worked for about 7 years in a hospital system after I graduated, doing primary care. Loved it. I started out loving it. And as time went on, I sort of started to see a lot of what I loved about it going away. It was a lot more, it's the hustle. Got to get through it, got to get to the next one, and started to sort of, get into a mode where patients would come in and I'd almost have answers for the patient before even hearing them out. And that's not a good thing. So it was the cookie cutter answer, here's your pill, here's your prescription, see you next time, let me know how it goes. Not really even any counseling on what we're doing here. So that was sort of a wake-up moment when I started to realize that's what I was doing. And I had to revisit this idea of why did I go into primary care to begin with? To build relationships really was the answer. It still didn't seem possible to have my own practice. Anywhere you look, actually, how many people here are part of or know of an independent primary care practice? 1 or 2, 3, okay. I mean, that's interesting, right? Cleveland's a very big city, and you don't have a lot of independence. And so, there's a lot lost there. Independent practices are eaten up and swallowed by the big systems, and there's a good reason for it, and we can get into it, but I'll fast forward. So then I found out about direct primary care, and I really didn't believe it to start. I really didn't think it was a real thing. It was something other people do out there, and how good for them and wonderful. And then I finally said, you know what, I'm just going to take the leap. And it really was a leap. There was this moment where, I had to turn to my wife and say, we're going to have to tighten the belt for a while. We're going to really, we're just going to do it. And it might take a year, it might take 2. And our income's going to be in jeopardy, and I don't know what's going to happen, but I went ahead and did it. So what is direct primary care? I'm not going to assume everybody really knows what that is, so I'll just, in a nutshell, sort of summarize it. DPC is sort of hinged on a couple principles. Number 1, there's no third-party payers. The relationship is between the physician and the patient, and nobody else. There is a fixed fee, meaning you charge a fee for a year or monthly, and that fee is fixed. It doesn't change, it doesn't vary, and there's no real, I can go into different variations of that. And then the third principle of that is that if you do charge a visit fee on top of it, it has to be less than the fixed fee. In my practice, we don't do that. There's just a fixed fee. So that's, in a nutshell, what direct primary care is. A quick word on concierge medicine, because some people will come to my practice and say, I'm so excited to join a concierge practice. And I don't correct them, and yet it really bothers me. So a concierge practice is where the fees are much higher. And those practitioners can also bill insurance. So you're paying a retainer fee. You pay the physician to say, you are my physician, and you're available and accessible to me always. But you're also going to bill my insurance for the visits that we do. And I think that inherently has some problems with it. Because the main reason I did what I did was to disassociate with insurance completely. Have nothing to do with it. There's actually a DPC practice I know of where if you say insurance, there's a jar, and you have to put money in the swear jar. So don't even say that word. So there's sort of overlap for concierge practices, but that's very different from what we do. So why would anybody, if they have insurance, decide to go to a provider and pay money out of pocket when they're already insured? Why would they do that? Well, in the case of uninsured, it's a no-brainer. They don't have insurance, and they finally can get care. And then there's a big group of people who are underinsured, and they have insurance, but it's not great. And we can go into that a little bit more as well. And then there's the insured. Commercial insurance, usually you have a high deductible plan, which means your insurance is expensive anyway. And then there's Medicare and Medicaid. Ostensibly, they're fully covered and have no real extra needs. So why join a DPC? Our practice offers direct access to the provider, to the physician. So we guarantee you same day or next day access, next business day access. So if you call in and say, I really need to be seen, and I need to be seen today or tomorrow, we get you in. Whatever we have to do, we get you in. When you call, oftentimes I pick up. And I never stop getting a kick out of it when a patient calls and I pick up, and there's a pause, and then there's like, I'm sorry, I wanted to reach your nurse or your secretary, and I say, no, that's fine, what can I do? And I just need a refill. I say, okay, I'll do it. So patients are really in shock when they hear me pick up the phone, and I love it. I never get tired of it. We do home visits. We have time to do home visits. We go out, and there's probably about a 20, 30-minute area that we assure everyone that we can do home visits. If you're outside that area, it's a little hard, but we do what we can, and we still do the visits. It's just harder to assure someone that you'll have a same-day visit at home. That's a very big deal, especially with COVID, and a lot of the elderly who choose to not leave their homes. So that's been a very eye-opening experience for me, being in the homes, and definitely learning a lot more about the patient than I ever signed up to know. Our visits are as long as you want them to be. So, 30-minute visits, 60-minute visits, 90-minute visits. On average, I'm doing 60-minute visits. We do 90-minute visits for introductory visits. We toyed around with 2-hour visits, but no one ever really took that long. Nobody would stay for 2 hours, so we were like, let's just make it 90 minutes. And then sometimes we do schedule people to say, come back tomorrow. We're tired. let's pick this up another day. And that's huge. I got very used to practicing in 15-minute increments. And your brain works very differently. And when I started to do 60-minute, 90-minute visits, I opened up a brand new part of my brain where I could talk to people and really understand what's going on, really get into the, oh, you're eating what now? Like, you're diabetic. No, that has to go. And I could talk, not, hey, I'm going to refer you to the dietitian, and maybe they'll do a good job, maybe they won't. Maybe you'll be motivated, maybe not. But this is direct with your doctor. Let's talk about it right now, and why that needs to change. So those 90-minute visits really, really helped me to actually use the skills I learned in medical school and in residency. Practicing at the top of my license, I could take time to look up diagnoses that I felt uncomfortable about. I could do it with the patient in the room. And I have no problem admitting to a patient, I don't know much about that, but let's find out about it together. It's amazing when you can admit that to a patient and how tremendous a response you get when they understand you're human and they know you're in it with them. That's really, really profound for patients. So we have lengthy visits. There's no real time limit, and patients book their own slots. So they go online and they pick. If they want a 90-minute slot, they get that. I don't tell them this is a 15-minute visit. We have some added benefits, which are we are allowed to dispense medications in the state of Vermont. I believe in Ohio you are as well. So what that means is we have a wholesale pharmacy that supplies us with medications, a lot of generics, not really any brand names. And we can provide it to our patients at cost. We put a slight margin on our meds. So like we pay $4.80 for our metformin, a 90-day supply of metformin, but we sell it for $5 because we don't want to deal with change. And we round up because the shipping and handling and the nurse's time to dispense. But that's really big. So we have a lot of uninsured patients who can now get medications when they never were able to before. In upstate Vermont, I never knew this, but there is actually a large portion of undocumented workers. There are people who will not go to the traditional, conventional medical system because they're afraid of registering and just being part of the system. So in a direct primary care, we're not partnered with Medicare. We're not partnered with Medicaid. We work for the patient. We have no reporting. We don't report to anyone. All we need is your name and your date of birth, and we provide you care. So for a lot of undocumented workers, this is huge. We have folks coming in who've never seen a doctor, who have illnesses, chronic diseases that need ongoing management, and they can finally get medications for them too. So we do on-site labs too. We've partnered with a lab company that helps provide us cheap labs. So has anybody had blood work done and with insurance or without insurance had to pay for blood work? So can anybody give me just one lab, how much it cost you? Does anybody want to share that? A CBC was $70. Anything else?
Can I tell you how much my Tylenol was in the ED on the student health plan?
How much?
It was $177.
Yeah.
Tylenol.
Yeah, so I looked up the Cleveland Clinic, and like a TSH is $140. I think a metabolic panel is $58. So we charge for a CBC $8. For a TSH, it's $8 as well. An A1C is around the same. And by the way, those are marked up prices. Those are prices because we don't charge a draw fee. We don't bill for the phlebotomy. Well, I do it or my nurse does it. So we have a little margin for, the shipping too. We ship it out 24 hours. The labs have to go to the lab within 24 hours. So we've marked up that pricing, just so you know. So if you just imagine that a rural clinic in upstate Vermont, where I live, can charge $8 for a CBC, what do you suppose the margins are in a large system like this where they probably run their own labs, right? Their costs are astronomically cheaper than mine. The cost to them, the cost to the patient is a different story. So, these are perks of joining a direct primary care. We have made it so that we're not putting a margin on those pills or those labs, because I can look a patient in the eye and I could say to them, I'm not ordering this because I make a profit on it. I'm not prescribing this because we make a profit on it. You're getting this because you need it. This is a trustworthy relationship. It's honest and it's transparent. Transparency is big. All our prices are up front. So you pay for a membership. It's for an adult, it's about $1,000 for the year. That's the price. You don't show up and find out, well, there's an extra bill. Oh, well, actually today you took extra time. That's a different bill. Or any other thing. It's all up front. And our labs are printed up front too. So, doc, I need my A1C checked. Here's the price up front. You don't get a mystery bill later. So this is a cornerstone for us too, is the transparency and the honesty, where we can look at you and say, we're doing this because we believe in this for you, not because it serves some other purpose. And I always remind patients, we don't take money from anyone or anything other than the patient. So we work for the patient. So reasons for why a patient would join a direct primary care. Now, why would you want to work in a direct primary care, right? So if you're a physician, what motivates you? Those lengthy visits, that's a big deal. How many years will you go jumping from room to room, 15 minutes, 20 minutes, maybe 30 minutes per visit before you get tired? And it really does get tiring. When you have all that time to spend with the patient, you have that time to spend with yourself too. You have that time to think, you have that time to really plan care, you have that time to actually spend on the patient, learning yourself. Time comes back to you. So when I was working in the hospital, they don't share this information readily, but I was able to find out, I had a panel of about 2,000 patients. Roughly about, on average, you see 1% of your patient panel a day, on average. So that means 20 patients a day. Now, it feels like I was doing more than that, but we'll just settle at 20 patients a day. In a direct primary care practice, we limit our patient panel to about 500 patients. That's so that we can actually deliver on those promises we made you. The promises where we say, we're here for you, we're going to come to your home, we're going to give you 90 minutes. We want to limit the patient panel. But on the other end, if you're seeing about 1% of your patient panel a day, that's 5 patients. Now, realistically, there's days where I see 20 patients, and there's days where I see 0 patients. So it evens out. But the point is, that's your time. Back to the fact that we don't partner with Medicare, Medicaid, we have no reporting requirements. There's no meaningful use criteria. I call it meaningless use criteria. You don't have to check boxes in the EMR. You don't have to prove that you did the A1C for someone else out there. Who are they checking? Are they doing anything with those metrics? How do those metrics incentivize you to be a better provider? I've never seen that. I've never realized that incentive. We don't have to do any of that. Technically, I don't even have to have an EMR. So CMS can threaten to not pay me anymore by not following their rules. They don't pay me anyway. So I don't need an EMR. I don't have to have any documentation. Now, it's good practice to have documentation, always document your encounters, but I don't document for billing. I don't have to put a ROS in there, a review of systems, and it's got to include X categories. I don't do any of that. Patient came in, sore throat, tested them for strep, they had a fever, dispensed this medication. It's done, that's it. No one's over my shoulder saying, when's your chart done? What you could have upcoded that. That could have been billed at a higher level. That was a high complexity case. None of that. That's huge. So my administrative burden is close to zero. Somehow I still end up having charts open. I actually chart more. I chart more now than I ever did before. My patient notes are long because I have time to do it, and they're valuable. I send a referral to a specialist, and I hear back, wow, because they're getting salient information. So I don't send them a packet that has all the, like vitals and medical history, everything. I send them a paragraph, and it's got the juice in there, So they love it. And what's better is I have the time to pick up the phone and call them. And I say, hey, cardiologist, this is my concern. The referral came through, but I want to let you know what I'm really worried about. And they love it, right? So communication is big. So that's a huge plus for doctors, right? For an incentive for you to think about this model. Money, right? So when I started practicing in Vermont, I'll be fully transparent with the finances here. My salary was about $230,000 as a primary care provider. So that's 2,000 patient panel. I had a 4-day work week with a 1-day administrative day, but let's be honest, that gets spent on patient care. So are you really using that administrative day? And pretty much running nonstop, right? So you can kind of do the math yourselves here. If it's roughly $1,000 a year per patient, and my panel is about 500 patients, so today I'm at 420 patients. You could do the math, right? So that's the income for the practice is at the 500 cap, should be $500,000. Now, it's not cheap to run a practice. We do point of care tests. We do like wound care. We do EKGs. We do all those things, but we don't charge the patient. So, we have to pay all that, the overhead. There's the rent, there's the lights and everything. So and I have to pay my nurse. I have to, pay any of the staff that are working there, phlebotomy. So you could say that that's roughly around $200,000 to run that practice. So you have an idea of what that could make, right? So now I'm not seeing that yet because I opened within this last year, so a lot of upfront costs went into opening the practice. But that gives you sort of an idea of the potential. Some direct primary cares say, well, I'm going to cap at 600 patients. I can handle the extra 100. Some practices, when you have another doctor, you would maybe divvy up the panel differently. Some practices only have 300 patients because you say, well, that's the lifestyle I'm happy with. If you're a family person and you say, I've got kids and I want to spend time with them, I want to do things with them, I'm going to limit my panel, and I'm in charge of that. No one's telling me this is your panel size. No one's telling me you have to work X many days. Here's another great thing. A patient pays for the year, whether they come, whether they don't. They can come every day, they can come every week, they could come once a year. And a lot of patients do come just once a year. You get paid. I'm in Cleveland giving a talk about DPC. I'm getting paid to be here while my practice is closed today. My nurse is there, she's doing work, she's handling calls, and probably getting some messages from patients right now. But the point is, whatever vacation I take, I'm being paid. Oh, speak of the devil, my phone's ringing now. Yeah. So, I mean, there's something about that, right? There's a bit of a comfort where if you have a practice where you have more than one provider and your colleague says, I'm going to support you while you're out for your 2, 3, 4-week vacation, or, oh, you're going to do some overseas work, you're going to be gone for 2 months, well, I'm going to take up that panel. You're paid. You're being paid, you know? So I see it as a win-win, right? So for me, I can't conceive of going back. I can't think of it. I can't imagine what my life would be. And my patients are happier. I can give you patient stories. I can tell you, actually, I'll go into a little bit of the breakdown, but my patients are happy. We get nothing but 5-star reviews. I'm not even trying. They're just happy. No, they're happy because of where they came from, right? Like what they were dealing with. You know, I hear it all the time. My doctor never looked at me. They were on the computer, and they didn't even turn to look at me, you know? I hear that all the time. So my patients are happy. I'm happy. I opened my practice less than a year ago, fully expecting it to take two years to really kind of get steady, right? I told my wife, tighten the belt. You know, we're going to be living frugally. And I have 420 patients today. So again, you guys do your own math, right? What do we do with some of that money? Well, I said, let's get a point-of-care ultrasound. Let's get portable EKGs. We've got this fancy AI technology that does skincare assessments for skin cancer. You know, if there's something cool out there, I want it. Let's get it. Let's provide it as a service to the patient for free. We don't charge for that. Yeah. Yeah?
So you mentioned specialists. So patients obviously still have to pay for that. So do most of them continue to retain some form of qualified insurance? Or like, so how do they handle like emergency visits or surgery
Yeah.
or specialists?
It is our recommendation always to everybody, have insurance. Have insurance, right? So people with Medicare, Medicaid, they're obviously not giving that up. Just a little tidbit there, I have to opt out of Medicare in order to have this practice. So there's a little kind of, there's a catch, right? You can't be part of the Medicare system and still provide this type of care. But that doesn't mean I can't refer, prescribe, or order. The patients who have commercial insurance, they can change their insurance plans. So a lot of patients who have high deductible plans, if they're using, that, let's say a $5,000 deductible, well, $1,000 gets paid to us, and we do all of their primary care with no charge. Someone calls in and says, there's been a laceration or they need to go to the ER. We say, no, come to us. We'll do that. There's no charge for us to do a suture or wound care or any of that. You know, if it's really concerning, go to the ER. It sounds like you're having a heart attack, go to the ER. You want to have coverage for that. But people have changed their insurance plans based on the fact that they've joined our practice. And it costs them $1,000 to do that, but when you change an insurance plan, you save a lot more than $1,000. Not to mention with medications, right? So if they're saying, well, we're just going to get our medications through this practice, and we price it out for them beforehand, we say, tell us all your meds, we'll tell you what it costs through us. You want to get it through us, fine. If you want to go to the pharmacy, that's fine. Again, we're not incentivized to direct you differently. And then, of course, with the uninsured, it's kind of a no-brainer, right? Like, we tell them you should have insurance because if you ever have to go to the ER, you're going to have to deal with that. But a lot of people in Vermont, there's a lot of these, agricultural workers, a lot of, salt-of-the-earth types. They say, well, we can't afford insurance. We're not going to pay for it. We still go to the ER when we need to, but then we just pay that bill. And those bills are crazy expensive. So we recommend everybody have insurance. The type of insurance you have, we can talk about that. We can help you navigate that.
You just kind of mentioned, excuse me, I guess, well, first, thank you so much for the great talk so far. Really loving it. Second, you kind of talked about being able to prescribe certain medications because of your kind of an arrangement you have with a medication wholesaler and labs you are able to provide with an arrangement via a lab. Given that you have such a small number of patients, how are you able to negotiate to get those
Yeah.
good prices? Because
Yeah.
that almost like seems too good to be true. Like, why do they even want to deal with you if you only are bringing a certain number of patients?
Yeah,
A low fee for the.
so it's not easy. That's the answer. But what's happening in the DPC world, a lot of us docs are very happy to share and help and work together. So there's actually groups of docs, and you can join like DPC alliances. It's DPC Alliance is actually one of them. And when you join, you get access to the group rates. You get access to like a negotiated rate based off all these other DPC practices that are doing the same. There are some geographical differences. So, being out in Vermont, there's probably a slight uptick for me because of how far my labs have to go. But again, the same thing goes for pharmacies. There's wholesale pharmacies out there that deal just with direct primary cares. And they know the mission, they support the mission, and they supply medications. I know that my prices are actually higher than some other prices out there. So I know it's even cheaper than that.
And so you would just pay a fee to the DPC organization to kind of be a part of that, or it's just a small fee to allow the organization to run or something? Is that how
Yeah,
it goes?
it's like being a member of like AAFP or something. So I think it was like $500. I think it was like $500 or something for the year. And then there's all these other perks too that you get you suppliers and wholesalers for other products, like gauze bandaging, and you're able to get some of those things at cheaper rates.
Awesome, and I do have one more question if that's okay.
Yeah.
Thank you so much. So I do realize that oftentimes generic medications are much cheaper and just as good as the brand name alternatives. What do you do when there is a new medication that's brand name that comes out that is much better and you do feel like it would be the best for a patient? Do you ever feel like you're kind of inhibited in terms of not being able to give the best care by prescribing the best medication? Or how do you deal with that if it's not part of your agreement with the wholesaler?
Yeah, so the example I'll give is like, instead of Coumadin, somebody's on Eliquis, right? So Eliquis is a brand name, super expensive. So I do a bit of the unsavory thing. I tell the farm reps, come on in. They come in, they can chat my ear off, and then usually I tell my nurse, I'm not available next time, but drop off your samples. And they're more than happy to do it, right? So I usually don't even get through all my samples. I have Trulicity, I have Ozempic, I have Rybelsus, Eliquis, Farxiga. I mean, a lot of these, and the more that hear about me, the more they come. Like you do have to entertain those folks, and you do have to listen. I will hope that I always stay impartial and unswayed by any kind of pharma influence, but there are times, as you said, where the brand name is better, and it's the best thing for the patient.
And they still are willing to come and kind of give you the samples even though you don't have the potential to buy from or to prescribe the medications normally in the future?
Oh no, we do. So commercial insured patients, we have plenty of. So I'll give the breakdown actually in a minute, but some patients have great insurance and are signed up with us. Some people. Okay, so approximately 1/3 of my patients are Medicare. And again, you would say, why would Medicare want to join, right? That they have insurance, they're paying for it already, and now they're paying additionally to see me. Now, those patients can still get all the prescriptions, and even the commercially insured patients. But again, they see it. They're saying, I'm waiting months to see my primary care in the conventional system. When I go, it's a brief visit. So I just spoke to a woman last week, and she says, I see my doctor once a year. She's telling me this. So I see my doctor once a year. I don't have any health problems. But when I go once a year, I want to be seen. I want to be checked out. I go once a year, do the full checkup. She goes for her Medicare wellness. Well, Medicare wellness is not a physical. They don't pay for that. A lot of doctors do it anyways, and they eat the cost or whatever. But she's upset by that. She doesn't like it, right? And also when she has a question, she calls. It's that, you get the machine, you get the nurse who says, I'll pass the message on. So she's essentially paid me for a year's membership just to come once, in the year. And so there are a lot of patients out there who are just unhappy with the conventional model, who ostensibly have no reason to join, but have a lot of reasons to join. So we do run into issues where, again, there's people who are uninsured and they can't go on the brand name. And then, we try to, again, get samples for them or try to manage them through other medications as best as we can.
That makes sense, and it sounds like it kind of works because you do have a mix of people in your practice as well.
Yeah, I have patients in my practice, as you can imagine. I've got lawyers, I've got government folks, I've got the poorest of the poor, and this is the only healthcare model that can see anybody, regardless of insurance, right? Otherwise, uninsured have no options.
Thank you very much. Very helpful.
Hi, so you mentioned that you've got undocumented people at your practice and uninsured people who potentially can't pay the $1,000. In the setting that they can't, do you offer payment models or do they typically pay up front? How does that typically work?
To date, we have never pursued anybody for an unpaid bill. And we will stand firm by that. We will not pursue anyone for an inability to pay. We make enough. That's the principle. This system makes a lot of money. How much is enough, right? So we don't pursue anyone for an unpaid bill. The ones who can, they do, and many people who are uninsured are desperate to pay it, and they want to pay it. I have a father of 4. He comes in, he cleans. He'll come in after, because it's a matter of pride for him. He can't pay for his kids, but he wants to do work. So, we say, well, you're going to mop after hours or scrub and do all those things. So we have a few arrangements like that for folks. We've never asked anyone to leave the practice. We don't screen our patients. The only 2 things we screen for is what's your age, so we know where you fit in the categories, and where do you live, because occasionally we get some characters from out of state who join just to, can I get a med refill? And it's like, you need to come in for your med refill, especially if it's like an opiate or something controlled. Those are the only 2 things we look at. Otherwise, we don't look at your medical history to decide whether you can be a member in our practice, whether you have high needs or low needs.
I'll ask a question.
Opening practice like this is obviously really complicated. So I guess I want to know, who did you go to for guidance on, like you mentioned, there are some lawyers involved, and then there's all the overhead and this. How did you even get this started?
Yeah, so that took a while. I really had made the decision far longer than, well over a year before I decided to actually do it. Again, the DPC community is very close. Any doc you talk to or call or phone, they're always more than happy to help out. Try it out, call a DPC practice, see who answers, okay? It's probably the doc. So there was a lot of great folks out there who gave me advice, who were very upfront about who I should partner with and what I should be paying for X, how I should bill. There's some organizations, so DPC Alliance, DPC Frontier, DPC Nation. They have a lot of information about the regulations, about the steps you want to take. You want to sign up for malpractice insurance, and all of these things that appear to be very daunting, and in the end are really just like fill out a form. It really sounds like this mountain peak that's hard to climb, and in the end you realize, my gosh, this was so easy. It's not that easy, but. In the end, it really isn't as complicated as you might think. And the upfront costs are pretty low. You just need a room. You need a room to start seeing patients. Patients want a relationship. They don't want a chandelier in the waiting room. They don't want the fancy leather couch. They don't want any of that stuff. And I was, again, concierge models and stuff, you see these beautiful waiting rooms, and you don't need a waiting room. Your patients don't wait. There's no waiting, So really, if you want to do it just very slim and trim, you don't have to get into a lot of expenses. I can hear you. Yeah.
I'm really loud, so that's fine.
I'm sorry, just for the recording, touch the silver disc, not the button on top. The button on top is actually the microphone. So when you cover it with your finger, I'm not hearing it. Sorry.
I was wondering if you could speak a little bit to the scope of practice with your patients. Something that I'm curious about is I'm really passionate about abortion medicine, and I'm wondering how you handle patients who might need to be seen a lot more frequently than others, and if that's ever been an issue.
We're very proud of the care we take of those folks. We serve from birth to death. We have another policy, which we don't advertise on the website or anything, but for our elderly patients, if you've been an established patient and you're hitting 90, we don't charge you anymore. Your care is free, and we're there with you till the end. So we do in-home care, we do hospice, we work with our local hospice team, the palliative care team. They love it, the teams, because when they call, I pick up. So the visiting nurses aren't getting, they're not faxing a report in. They're talking to Dr. Malik. They're in the home, and they're like, Miss So-and-so doesn't look so great today. They're getting direct input on what to do and what's the next steps. If we need to see you 2-3 times in the week, we arrange it. We had someone we were doing wound care for, and we said every 2 days you're coming in until you're sick and tired of seeing us. So again, when you think about your patient panel being smaller, you're not seeing as many people in a day. So when I say that I had a day where there's 20 patients, many of those were just the walk-ins to be like, let's check your blood pressure today. You don't have a cuff at home, just walk in, do a blood pressure check. You don't like doing the glucometer, I'll call them up and I'll say, come on in, we're gonna do your point of care right here. So those we enjoy that. That's what I went into medicine for. I don't want to do cursory care. I want to do thorough care. Now, you can do this any way you want, right? So some people say, well, I don't take care of X problem. I don't do this. There are DPCs out there that only do pediatrics. There are DPCs that only do up to the age of 60. And after that age, you have to see a different provider. So you're free to design your own practice to say, like, there's conditions I like to take care of, and there's conditions I don't like doing a lot of women's health. So I do refer some of those out. And some, for example, uninsured say, well, I need my pelvic. We'll do it. We do it. Not to say that I won't do it, but it's just that, that's not an aspect that I'm passionate about. So you can pick and choose, right? As so long as it works for the patient as well.
I'm curious, what is your relationship with other healthcare hospitals in your area? Do you get admitting privileges? How does the EMR system work?
Yeah, so there was a bit of a tricky path because the hospital system in my area, I left to do this. So there's obviously a little bit of, there's a delicate path you have to walk. But again, in an area where I'm in, we basically made an appeal saying that, this is a primary care clinic offering care to a lot of people who have the need, and you can't really lock us out. You can't really say that we can't admit or refer. They still benefit from those referrals, right? So they're still making money off that, so they're not going to turn those away. They don't like that we have labs that are far cheaper than theirs. They don't like that there are some things that we offer for free and they bill for. We still have to navigate that a little bit carefully. But a lot of the referring docs, a lot of the local docs, I can't tell you what it means when you pick up a phone and talk to somebody rather than just doing the fax or like a text message. Everybody knows patient cares can't be summarized in a text message. You know, you can't assume they understand what your needs are for that patient. So all the specialists love the fact that they can call me and I can call them. You know, I used to think it was annoying that you can call a doc, I'm so sorry to bother you. And I realized they love those calls. That's the time when they can get a real picture from potentially someone who's spending a lot more time. You know, so this is getting really complicated with psych care because we don't have any local psych, and we have to refer out 2 hours out to the psych practice that's actually seeing patients. But to be able to call them up and discuss a lengthy case, and they're like, wow, you know a lot about it. I said, yeah, I spent 90 minutes with the patient. It means a lot to them too. So specialists love it. They love that they can rely on us for that. Yeah, so I'll back up. When I was working in the hospital system, we would do call like 2 or 3 nights a week. Okay, so I was on call 2 to 3 nights a week. I get less calls now than, and now I'm on call 24/7, right? I get less calls now. You could text me, which is a whole world different, right? So you can text me, and when you know you have access to your doctor the next day without any kind of barriers, you're not gonna call them at 2 in the morning. It's really, I was told this and I didn't believe it. I was worried about that aspect of it. I have never once been called in the middle of the night. I do get some urgent calls sometimes, and they're pretty valid calls, like somebody actively having chest pain, okay, walk them through it, go to the ER. I get the people who text a lot, you know, and I have an auto message that says, hey, you're texting after hours. If it's not urgent, we'll get back to you tomorrow. You can press this button if it is urgent. So, you know, we get some of those folks that really need a lot of love and care, but they really, just again, them knowing they have you really quiets down their anxiety. Text messaging your doctor is pretty cool. I love it, right? I don't have to spend 30 minutes on a phone call, right? I could just say, I hear you, I'm sending in a prescription, you know, conversation over. Or, you know, that's another thing, right? The conventional system works on the principle that in order to get paid, in order for it to all work, you gotta come in, right? You gotta come in. You have to come in, it has to be a visit. It has to be documented, and that's how it gets billed. We don't work that way. You know, the woman who I know gets UTIs every other month, and she's a pretty in-tune person. She knows her body, and she calls me and says, Doc, I'm having those symptoms again, and it's burning and it's irritating. And I'm gonna say, well, you know, I'm getting all the information I need. You don't need to come in. You don't need to come in. The mom who calls and says that, oh, remember you saw Jimmy for strep throat? Now Susie's got it, right? Like 3 days later. Now I'm gonna tell her, come on in and let's check Susie. No, you know, like, we don't have to play that game. Those games are over. If you are a provider and you know your job and you know you can take care of something, you don't have to drag them in. And for that working mom who's got, you know, 3 kids, that's a big deal. I'm home some days 3 o'clock, you know? I go home and I'm home before the kids. So my family, obviously they were ready for it to be rough. They were ready for it to not go well. Financially, we're okay now. We've hit that point. And we're expanding, so we're at now a point where we're saying, let's get another doc. There's enough of a need. There's enough people asking to come in. Let's open another one. Let's have another doc do it. The next town over, let's get one in there. My family couldn't be happier. I mean, yeah, sure, we get an odd text message during dinner, and try not to answer it during dinner, but for the most part, I'm more present. I'm more relaxed. I'm not so snappy anymore, I think. Yeah.
You had the whole little group over here laughing about that snappy comment. We've all been there. Two real quick things. One, can you finish the breakdown? I was curious about the uninsured fraction of your practice.
Yeah, yeah. So about a third is Medicare, which again, you wouldn't have assumed, right? About half are commercially insured, and then a little less than a third are uninsured. We actually have another group where it's employers. So employers so the local mechanic has 10 employees. He can't afford insurance for them, so he doesn't, so his employees are not insured. But he's saying, well, I'm gonna pay for all 10 of my employees to sign up for direct primary care as the incentive for the patients, and to even in just some cases, I just wanna do what's right, you know? A lot of those undocumented workers, it's the farmer who's employing them has come to me and said, I want to sign up, because they don't want to come out. They don't want to come in, you know. So the farmer comes out and says, I've got 3 undocumented workers. I want to sign them up. I want to pay their care, you know, because they're working, they're sick. He pays when they go to the ER, if they ever had to go to the ER. There was a bill, so he said it was $1,300 to have a suture done, because they cut their hand while they were harvesting something. So they cut their hand. We do sutures for free, right? Like, as long as it's not a complex laceration. So, you know, we are getting, so we don't count those as uninsured, we count those as an employer group. And so there's more and more of those folks joining as those employers talk to other employers and say, you know, we never had anything before, but now we do.
Thank you very much for that. And can you speak a little bit to the other services that you offer that aren't membership-based? Like, do you offer procedures and other services that aren't part of the membership? And then how do you handle vaccines?
Oh, right. Okay, so vaccines. So thankfully, and not everywhere is like this, but thankfully in Vermont, there's a great vaccination program. And so regardless of the practice, and however, up until they hit Medicare age, so 65 and younger, the Vermont VCHIP, I think, Vermont Child and something immunization program, they help out. So they supply the vaccines. They require you to not charge past a certain amount for vaccine administration. We don't charge for anything like that anyway. So there's a few things you have to sign in order to become part of that program, and then they supply us all our vaccines. For Medicare and any vaccine that would typically not be covered through that program, we say, go to your pharmacy, pick up your vaccine, bring it here and we'll administer it, or the pharmacy will administer it. So I know there's some states where it gets a little tricky because there aren't as great programs. In those cases, there are, again, through those alliances where you can find these wholesalers. They're not cheap, but you can still get access to vaccines cheaper than they would relatively be. We do biopsies. So as far as procedures go, we do biopsies. We do mole removals, skin tags, all those minor procedures. We do them in the practice. Again, it's part of the practice. We do have an aesthetics practice on the side, and that's considered a separate business. So Botox, fillers, cosmetic stuff, and that's a very different patient population. And so having a practice like this, I have time to both manage a practice and then also have a separate side to the business that offers those services. So that's so much more possible because there's days where I have 3 primary care patients and then a block that's empty.
I was thinking of my own experience. I worked with a big prepaid HMO, and then when we started our family, I said, oh, I want to go part-time now. And I had to go through a lot of rigmarole to get that. Finally, they said, okay, fine, you keep your 2,000 patient panel and you can work half-time, which was a challenge. But luckily, I knew my patients and
Yeah.
a good nurse, and we made it work. But this is a great system where you could limit your number of patients and have the part-time options.
Yeah.
I really like that aspect.
Yeah, we've talked to nurse practitioners who want to join, and you know, a lot of times they'll ask, well, what's the schedule? And I'll say whatever you want it to be, because it's a partnership with your patients, right? So if your patients know you well, and it's something where you say, I only work Mondays or Tuesdays, and your patients know that, and they know they can access you on those, and then of course they could see the other provider the other days. That works. You know, again, if you're thinking about 1% of your panel and your panel's 200 people, you get a rough idea of how busy you're going to be. That's on average, right? So there's days you'll be busier.
I was also going to ask about what are the different models for shared practices? You've been solo, but someone covers for you, and then what are some different models for a 2-person practice or a nurse practitioner, or how does some of that work?
Yeah, so there's a lot of variations. There's actually practices out there that in some states you can be a nurse practitioner and practice without any oversight, medical oversight. So there are DPC practices where it's just a nurse practitioner running it. Overall, patients like the model where they have the doctor, and that's what they would prefer, and that's what they're signing up for. I think it's a good model when you can have a mid-level with oversight of the physician. So this was another thing that I was running into at my hospital. So when I was working there, they were increasingly shifting to mid-levels. So again, nothing wrong with that, except that there was a time where I'm the MD, and somehow, and beyond my knowledge, I had 4 mid-levels working under me. I said, I don't even know if I've met some of these people. They've never consulted me on a patient, and I don't know what they're doing, and yet my name is attached to them. So that obviously had me a little concerned that more and more of the care was being passed off to the mid-levels without, and under my license, without my oversight. This seems to be a trend in a lot of places where, one doctor per a couple or a handful of nurse practitioners or PAs. For some people that works, but I think, again, I believe in mid-levels, but I think there should be a really good relationship so that you have the time to oversee those. You have the time to actually say, these are patients I've looked through and I review their care. But again, it's really nice when you have another partner and you could say, well, I'm going to take 4 months off. And if you're okay handling 10 patients a day instead of 5, which I'm sure a lot of people can easily do if they've been in the traditional system, and then swap. I'm back from my world travels. You can go on your vacation now, and I know some practices that have done that. It's kind of a dream.
Just to follow up on that, what do you do if you want to take a vacation for a week or 2 and go out of state or something? What do you do because you're a solo practitioner in terms of call and things like that?
Right. So I still have really good relationships with a lot of the other physicians that I worked with. So occasionally we'll just ask them to cover for nights like tonight, where if there's a call that comes in, it gets routed to one of the other providers. There are services out there where you just pay for on-call coverage. You can hire these professional services that after 5 p.m., the call goes to their to their company, and they handle all those calls. Obviously takes a little bit away from what you're doing, but it makes it possible for you to step away so that you're not just tied, you're not chained to the place. Again, there's overhead for that, but if you have colleagues who are helpful, and like in my case, I'm lucky where a friend just says, yeah, I'll take the call. I mean, it's usually one call or even a text message, which most of the time waits till the next day anyway.
And so in terms of, I guess, in terms of also being away, what do you do with kind of like the next day care? That also just goes to whoever is on call for you?
Oh, right, yes.
Right, yeah, like, because if a big hallmark of your practice is like, oh, I can get you in the next day, so you don't need to be calling me in the middle of the night, right? What if they
Yeah.
can't see you the next day because you're gone for 3 weeks or something?
As most physicians are, as most people who are probably here, I am a bit OCD. And so even if I'm away, I end up checking, checking in. And again, that check-in is like maybe 30 minutes to an hour a day because I'm not doing documentation. I'm not doing, just signing off on a script here and there. The nurse says, what labs do you want on Mr. Smith? So I've taken vacation where I'll be away for a week and I'll still check in and, just keep things moving without relying on anyone else. So again, we are so bogged down by what the conventional system tells you have to do. You don't have to have people in the office, right? Patients don't have to come in for that visit that you could just handle with a quick phone call. Doc, I'm having palpitations. You call them up. How's it going? What's going on? Well, you're stressed. Let's talk about it for a second. You don't have to come in, right? Because it's maybe their anxiety flaring up. You know that patient well, right? You've given that time. So for a lot of people, coming on site, there's days I'm sitting in the office and someone walks in and they're like, "Where's everybody?" I said, "This is it. This is how it works." There's days where there's nobody in the office. They don't come in. We're still working. We're still taking care of things, but the conventional systems trained you to think like it's this unbelievably insurmountable, workload, and it is, but because they've made it that way. Insurance creates a lot of work, right? Like if you look at any hospital system, look at how many employees they have for billing, for coding, for charting, for calling up insurers. That's where the overhead goes in a traditional private practice. That's why you can't survive out there, because you're paying all these people. My hospital system, over a third of its budget was for software, was for EMR. Over a third of a hospital's budget was not going to patient care. That is just mind-boggling. But it's because of all of the insurmountable tasks and clicks and things that you have to do because you have an EMR. Not being part of Medicare, technically, I don't have to abide by HIPAA. I don't advise people to break HIPAA, right? Like we still honor HIPAA. There's no stick out there for me. There's no stick, right? The CMS is all about if you break these rules, we're not going to pay you. They don't pay us anyway, right? So nobody can shake a stick at us. I mean, do due diligence, do good medical work, right? You still answer to the board. You still answer to your patients. Actually, this is my big piece. You're always accountable to your patient. So that work that you get to see on day in and day out when you're in and out of here, everywhere you go, this is what they've made it into. Doesn't have to be that way. Yeah, it's my dream to have a licensed counselor in the office, and there are some. Again, the beauty is as the practice grows, you don't pay for those additional things. Your model is on memberships. So the more memberships you have, the more things you can put in there. So there are practices out there. The biggest limiting factor is there's not a lot of people, there's not a lot of bodies for there's not a lot of psych, there's not a lot of counselors, there's not a lot of therapists. I mean, we need to triple them, right? So yeah, that's the dream, and I fully have that on my vision board. So it is always if I'm ever coming across someone, that's a conversation I'm happy to have with them. And I've seen some models where they have social workers and they have, dietitians, they have personal trainers on staff, you can add any number of things.
What do you do, any role when your long-term patients are in the hospital?
Yeah. So I think somebody asked about admitting privileges, and I'm not sure I answered their question. But so if my patients are in the hospital, I'm on the medical staff of the hospital. I'm an unemployed medical staff member. I should back up and tell you that during my 7 years there, I was actually president of medical staff for a while, and I actually sat on the board for a couple years. So I got to know a lot of the ins and outs, if anybody wants to talk more politics and finances. But because of that relationship, I remained on medical staff. And so I can't bill for any care in the hospital, but I can go in and I can sit with my patient, I can speak with my patient, and I can speak with the hospitalist who loves the input because he's run thin anyway. He's caring for X amount of patients, and he doesn't have the time to gather a full in-depth history. So I'm welcomed in the hospital. They see me coming in, even the nurses. I have time to chat with the nurses. How are they doing? By the way, they have that little sore, don't forget. And so they welcome it because they get an input about the patient they would never get. I do think we take a little load off the hospitalist by providing them that background information. And the patient loves it too. You get to visit them and they see you and they see a familiar face, and it's a harrowing experience for them anyway, and to begin with. So, yeah.
I did, yeah. My question was, as someone who's been kind of bought into this for a long time but doesn't yet have my practice, I'm really interested in your nurse hiring and how perhaps, getting yourself into that mindset, but in terms of having a staff person that also kind of gets it, how hard was that?
When I started, I had no nurse. I was doing it just myself, taking blood pressure. By the way, I still do it myself. My nurse answers the phone, and that's it. Occasionally, I'll have her come in and do an EKG while I'm talking to the patient, or I do the blood draws, I do the blood pressure cuff, I do the oxygen, the temperature, I do it. I don't need the nurse, I don't need her to chart. This isn't being facetious, it's just that I want to be doing it, and the patient wants me doing it. In a traditional model, you have that nurse because they want you seeing more patients, right? So the nurse rooms while you're going around. So in my model, I don't need that. Now I have a nurse because it makes things so much easier, and I don't have to deal with some of the refills and some of the calls. Now, I was lucky in that I worked with my nurse in the hospital, and I knew her for years, and so she knew my model. I knew how she works, she knows how I work, so it was a natural transition. I have a waiting list of nurses that are desperate to work with me right now. I have a list of nurses that I am worried, when I hire one, I'm gonna have to tell the others I didn't hire you. So I don't know how I'm gonna handle that. Why is that the case? Because they're exhausted too. They're exhausted with all the work they have to do. And they can see how much easier a model like this is. I have told them, I can't pay you what the hospital pays you. I tell them all the time. I'm trying to tell some of these nurses, I can't hire you, right? And they're like, we don't care. Just tell us when you're hiring next. Because they know that they've got, my nurse right now, if her daughter is sick, she doesn't come in. She stays at home and answers the phone. The phone routes to her phone. So she answers, she does all her work, and she's right next to her little one. She had COVID and was doing work from home. I told her not to, but so for her, it's like, it's not even a lot of work, right? So you'll find a lot of nurses out there who know that they are good workers and they know they're worth it and they know they don't want to do it anymore. And hopefully, that's a good match for you. But that's not a problem I have. It was shockingly, because the hospital is in desperation to hire more nurses, and I have a list waiting.
So Umair,
Yeah.
thank you so
Yeah, thank you.
very much. I had the privilege to work with Dr. White at the medical school after he retired from his practice while he was still teaching. And he and I had a lot of conversations about the joy of primary care practice and the joy of being in relationship with patients over time. And we lost him a few years ago, but I can tell you, knowing what I know from our interactions, that he would have loved to hear your talk tonight.
Thank you.
You embody the things that he loved about practice. And so I thank you for being the inaugural lecturer as we really kick this primary care series back off again and really try to get people excited about the joy of primary care. And I'm thrilled that we had both family medicine and internal medicine colleagues and behavioral health colleagues here tonight. And I hope that this planted a seed, or maybe watered seeds that have been previously planted for some of us, about what we can dream about doing, and we can care for patients in a really meaningful way. So I just want to thank you for being here and for the inspiration and the courage to step out and do this without a safety net. It's really amazing. So thank you. And I'm just super proud of you as your former faculty, because every time you see one of your former residents or students thriving and making the world a better place, it's very rewarding. So
Well,
definitely
thank you.
feel about
Thank
that.
you for having me.
And so we're glad that you may be able to meet with some of the residents tomorrow. So hopefully you can get that spark in them too, because they're closer to being out. And I just want to finish also by thanking our Cleveland Fire Lieutenant colleague in the back of the room. Thanks for being here for us. Thank you. We appreciate you keeping us safe. And for Paul, who's behind the wall over there, but always keeps us AV, and for probably more than a decade, he's made sure that I don't look ridiculous up here. So thanks, Paul. So thanks everybody for coming. We hope this is just the beginning of our conversation, and look forward to the next one. Thanks much.